Medically Assisted Treatment Critical Assignment Project, Enrique Gonzalez, Cal Baptist University. Opioid addiction has created a crisis affecting individuals, families, and communities, not only in many cities throughout the United States, but also the world. Injecting this drug has many risks at hand, such as HIV, AIDS, and hepatitis C, through the sharing of needles. Medically assisted treatment is any treatment for opioid addiction that includes methadone, buprenorphine, and naltrexone, approved by the U.S. Food and Drug Administration for opioid addiction detoxification or maintenance treatment. Each one has its own advantages and drawbacks. Studies continue on opioid addiction and treatment to clarify what works to increase successful outcomes as evidence-based methods. The objective of this paper is to provide information on the barriers and accessibilities to MAT, medically assisted treatment services, and to formulate a plan with methods of implementation. For decades, research has supported opioid addiction as a medical disorder that can be effectively treated with medications under conditions consistent with their pharmacological efficiency when in collaboration with comprehensive services such as psychosocial counseling, treatment for co-occurring disorders, medical services, and vocational rehabilitation services, as well as case management services. Medically assisted treatment and its medications, buprenorphine and naltrexone, have been popularized in recent years with the wonders of being tapered off of the medication in a safe manner rather quickly, whereas methadone treatment might take years to taper off if a physician sees that fit. Opioid use disorder maintenance programs have been effective for achieving long-term sobriety and a sense of normalcy for individuals who suffer from an opioid use disorder. However, accessibility is not always provided for the individual, and barriers conflict with the continuum of care. This could be due to medical coverage and/or accessibility to medically assisted treatment community-based programs. Today, with the help of community-based 12-step programs, individuals with an opioid or substance use disorder have a better chance of being successful in obtaining long-term sobriety. Many individuals have encountered barriers with the lack of medical insurance to cover prescription medications, treatment, lack of physicians and specific treatments at facilities offering support, and some have had attitudinal barriers as to the incorporation of medication into the culture of recovery-based programs, such as the 12-step communities of Narcotics Anonymous and other self-help programs. Many don't understand the recent evolution of evidence-based medically assisted treatment programs. Because of this, many are often adverse to a medically oriented approach to addictive disorders. Thus, new attendees who may be on methadone or buprenorphine maintenance, and even once prescribed naltrexone, have been sidelined in the fellowship meetings or discouraged from speaking there. Methadone care offers a secure and efficient way to stabilize the function of otherwise difficult narcotic addicts. Methadone has been used for decades as a substitute and medication for opioid use disorders. However, methadone has had a negative adverse reaction to many who choose to have this medication induced. Methadone medication has a very powerful effect, and individuals can become dependent on the medication with being tapered down at a slow rate. Medication such as buprenorphine has had a much healthier outcome when administered. Many individuals praise the medication tapering off within a few days or continuing on a maintenance program with minimal daily doses. Barriers and accessibilities come in many different forms. We must look at treatment facilities that are not affiliated with the hospital. We can consider these limitations and deficits as barriers to obtaining long-term assistance in any form of medically assisted treatment services. This represents a large number of treatment centers in the United States that provide services for more acute substance use disorders. Funding barriers include the cost of physicians and insufficient repayment by funders. Were negatively associated with physician employment. Rehabilitation centers have been oblivious to the availability of state contract money to pay for medical staff. Those have employed fewer doctors, rather than facilities that are aware of the availability of state funding. Physicians have not been too keen on offering medically prescribed drugs to an addict. If the subject came up in discussion, a typical physician would say that addicts are morally weak, they need discipline, not medical treatment, and certainly not a medically prescribed drug. Although facilities have struggled in adding physicians to their payroll, physicians do play a key role in bringing wraparound services along with evidence-based treatment practices. It is difficult to come to terms knowing that there is an opioid epidemic in our country, and we see the struggles of obtaining sufficient support in our communities. With the lack of physicians willing to address the issues and facilities understaffed with the appropriate medical team, individuals struggle with these barriers. In the U.S., the problem appears evident in comparison to countries like France, where the widespread medical prescribing of buprenorphine has yielded a decline of more than 50% in opioid deaths due to overdose. Of the 810,000 practicing physicians in the U.S., only about 5,000 members of the are members of the medical addiction societies, showing how critical low physician expertise is in this epidemic of the opioid crisis. With the implementation of the American Society of Addiction Medicine screening tool and placement criteria, the placement criteria has revolutionized the medical necessity and individual meets and level of placement. This screening tool identifies patient or client placement at the appropriate level of care and classifies residential facilities into those which are clinically versus medically managed. Those described as clinical do not meet the requirement of having physician coverage. And so this loss of coverage is made apparent in the important medical services which cannot be provided on the spot because of lack of appropriate physician staffing, creating barriers to appropriate services needed. With the implementation of medically assisted treatment services and an added community-based 12-step self-help program, statistics show that an individual has a 92% better chance of being successful in achieving and maintaining long-term sobriety. Success has been accomplished when an individual has implemented a medically assisted maintenance program and has included programs such as 12-step based psychosocial counseling, co-occurring treatment, and case management services. With accessibility to treatment, a proper assessment completed, and an evaluation made by a physician, an individual who suffers from opioid and other substance use disorders can be properly placed at the right level of care and begin receiving services they need to balance their life. There also has come to light barriers of two cultures. The anonymity of 12-step members and the non-affiliation of outside groups, including medical centers, gives poor effectiveness to clinical research because of the limitations in experimental designs. Naltrexone and buprenorphine have recently become very popular in San Bernardino County and the state of California in recent years, with the implementation of Drug Medi-Cal, DMC, through the county-funded programs from the state capitol in Sacramento and the Department of Healthcare Services, DHCS. An explosion of MAT, medically assisted treatment services, has occurred. To help curb the mortality rate of opioid-based users, programs and funding have been implemented in rural communities throughout the state. Screening and assessment referral centers have been put into place by most counties to give proper screening and accessibility to opioid use disorder patients at the right level of care. With the use of the ASAM tool in most county-funded and contracted facilities, clients are better placed in the appropriate level of care in which they qualify in. As mentioned above, both naltrexone and buprenorphine have been popularized in the more recent years due to severe withdrawal and life-threatening concerns with medications such as methadone. The use of methadone has its drawbacks in the form of severe withdrawal. Tapering off the methadone can take years to drop down in dosage. With buprenorphine, a taper can be medically supervised in as little as months, weeks, and or days, depending on medical advice. Implementation takes place when the barriers and deficits in substance use recovery facilities are addressed and removed, when adding qualified physicians to staff, and working with other community-based resources to offer services, creating a community-based program that includes a web of treatment facilities and outside resources such as hospitals, methadone clinics, and qualified staff to help monitor the implementation of such programs. The County of San Bernardino has a program connected with Arrowhead Regional Medical Center called the ED Bridge Program. But is that enough? An increase of accessibility is needed With the explosion of MAT services in recent years, more programs still need to be developed to induce patients and clients alike. With an increase of opioid-related overdoses and deaths, more programs are needed. There is a 2 to 3 week wait list to get opioid use disorder patients enrolled in an outpatient program, even longer for a residential at times. After leaving a withdrawal detox unit, this wait list is just way too long. Isaiah 41:13 states, "For I, the Lord your God, will hold your right hand, saying to you, fear not, I will help you." This is why I have entered this field, to help those who are still struggling. Why? Because I know what it's like to hit rock bottom due to substance use. God has reached down to the pit of hell that I was in and pulled me out, showing me the light again, and has blessed me with the keys of knowledge to assist others who are still laying in that pit. The psychosocial theory of human services clearly explains that individuals are shaped by their social environment. This is my morning meditation, to help, even if it is just one individual, change their mindset, the way they think, so that the way they behave and the actions they portray can be that of a healthy lifestyle and not one of destruction and disappointment. By applying the social learning theory, individuals learn by implementing new behaviors, not only listening and observing, but actually doing the action, creating new behaviors to change the mindset. If we can implement all that has been explained, we have a better chance of seeing some real change in individuals who struggle with the opioid use disorders. Amen? Thank you.